Okay, picture this. You've been living with this nagging stomach discomfort. Maybe it's a burning pain, right in your upper abdomen. Or maybe you feel uncomfortably full after just a few bites.
Yeah, it's frustrating.
Totally. And you push through, go to the doctor, they run like every test imaginable, endoscopies, blood work, scans, and everything comes back. Well, normal.
Right. Clean bill of health, but you still feel unwell.
It's maddening, isn't it?
Yeah.
You know something is truly off, but there's no clear diagnosis.
Yeah.
If you've ever felt that really frustrating disconnect between persistent symptoms and, nothing showing up on tests, then this deep dive absolutely designed for you.
That feeling of being unwell yet undiagnosed is incredibly common, actually. And today we're hoping to cut through some of that confusion.
Good.
We're taking a deep dive into functional dyspepsia, often just called FD.
FD, right.
It's a chronic gastrointestinal disorder. Think persistent or recurrent upper abdominal pain, discomfort, or maybe that feeling of getting full way too quickly. But the crucial piece, and this is where it really challenges our sort of typical understanding of illness, is that there's no identifiable organic, metabolic, or systemic cause that traditional tests can pinpoint. It's a genuine mystery for a lot of people.
And unraveling that mystery is precisely our mission for this deep dive, based on the sources you've shared with us. We're going to unpack the current understanding of FUD.
Yeah.
How it's classified, what complex mechanisms might actually be happening sort of behind the scenes.
Yeah, the why.
Exactly, the why. And the journey to diagnosis, and then the different approaches to managing it. By the end, you'll hopefully have a much clearer, more nuanced picture of this often misunderstood condition, helping you feel truly well-informed.
Let's hope so.
So let's start by truly defining this elusive condition. What exactly is it?
Okay, so at its heart, functional dyspepsia refers to those chronic upper abdominal symptoms we mentioned. Pain, discomfort, getting full too early, when, importantly, no structural disease is found to explain them.
Right, nothing shows up on the scope.
Exactly. And it's not just like a random collection of symptoms. It's a recognized diagnosis classified under the Rome-4 criteria.
Ah, Rome-4. I've heard of that.
Yeah, it's this framework established internationally for what are called functional gastrointestinal disorders, or FGIDs. And it was, honestly, a monumental shift.
How so?
Well, it finally provided a concrete, research-backed way to classify conditions like FD that previously just baffled both patients and doctors because they lacked those visible organic causes. It essentially legitimized symptoms that had no clear physical sign on a scan.
That's huge, because it means symptoms aren't just dismissed as all in your head, which I'm sure happens.
Precisely.
And the sources, they break down FD into two main presentations, almost like two different faces of the same condition. Could you walk us through those?
Absolutely. So the first one is called epigastric pain syndrome, or EPS for short.
EPS.
Okay. This is that sharp, sometimes burning pain located mostly in the upper central abdomen, the epigastrium.
Right up top, under the ribs.
Exactly. And what makes this subtype a really crucial diagnostic clue, setting it apart from other gut issues like IBS maybe, is that this pain is not relieved by going to the bathroom or passing gas.
Ah, okay. That's a key distinction.
It really pins the problem higher up in the digestive tract. Then the second subtype is postprandial distress syndrome, or PDS.
Oh, PDS. Got it.
This one is marked by that really uncomfortable sensation of postprandial fullness. Feeling uncomfortably bloated and full after meals.
Even small meals sometimes.
Yes, sometimes even small meals. Or early satiation, which means getting full incredibly quickly, often unable to finish what would typically be a normal-sized meal for you.
Okay, that sounds really disruptive to daily life.
It definitely can be. And PDS can also bring along other symptoms like general bloating, maybe nausea, or excessive belching.
It sounds like they have pretty distinct calling cards, EPS and PDS. But given how complex the gut can be, do patients ever experience like a mix of both?
That's a great question.
And if they do, how does that complexity impact things? Diagnosis, treatment?
Yeah, that's a really good point. And yes, our sources absolutely confirm that it's quite common for patients to experience overlapping features of both EPS and PDS.
Oh, okay. So it's not always one or the other.
Not at all. And this often means management needs to be really tailored to whichever symptoms are most bothersome for that individual because, different mechanisms might be driving the pain versus the fullness.
Makes sense.
Now, you might be wondering, well, how common is FD overall? Who typically gets it?
Exactly my next question.
Yeah.
Is this a niche condition Or is it more widespread than we think?
Oh, it's far more prevalent than most people realize. Functional dyspepsia affects somewhere between 10% and 20% of the global population.
Well, 10 to 20%, that's a lot.
It really is. And while it can show up at any age, it's most frequently diagnosed in adults between, say, 20 and 50 years old.
Okay.
And statistically, it's seen slightly more often in women.
Interesting. Any idea why?
The reasons aren't fully clear, possibly hormonal influences or differences in pain perception or reporting, but the slight female predominance is consistent in studies.
Right. And is it global? Or more common in certain regions?
Interestingly, its prevalence seems pretty similar worldwide, although how symptoms are perceived and reported can vary a bit due to cultural interpretations of discomfort or pain.
Okay, so we've defined the elusive what FD, and we understand its scope is pretty significant. But the true enigma, I think, lies in the why. Since those standard tests come back normal, it feels like the body is telling us a story we haven't quite deciphered yet. What clues do our sources give us about the complex mechanisms actually at play here?
This is really where the deep dive gets fascinating because, like you said, there isn't one single obvious cause you can point to on a scan.
Right.
But several mechanisms are strongly implicated. One significant player is impaired gastric motility and accommodation.
Motility and accommodation. Okay, break that down.
Sure. Imagine your stomach as a finely tuned machine. In about 30% to 50% of FD patients, that machine experiences delayed gastric emptying.
So food just hangs around longer than it should.
Exactly, it lingers. Then there's also impaired gastric accommodation. This means the stomach fails to properly relax and expand after you eat to comfortably receive the food.
So it doesn't make room properly.
Right. It stays a bit too tense, if you like.
Yeah.
And then there's also something called antral hypomotility.
Antral
Hypomotility.
Yeah.
It means that critical squeezing action in the lower part of the stomach, the antrum, is weakened. So it's harder to push food along into the small intestine.
Okay, so the stomach isn't quite moving things along or expanding as it should. That makes sense as a source of discomfort. What else might be contributing?
Another core mechanism seems to be visceral hypersensitivity.
Visceral hypersensitivity. Sounds unpleasant.
It is. This isn't about the stomach creating dangerous signals. It's more about the gut and the brain becoming oversensitized to completely normal sensations.
Like just stretching after a meal.
Precisely, like normal gastric distension. It's tied into altered signaling along that gut-brain axis we hear so much about.
The gut-brain connection.
Exactly. And abnormal processing of pain signals in the central nervous system. It's kind of like the body's internal alarm system is set to an incredibly low threshold.
So it rings the alarm bell for everyday stuff.
Basically, yes. Reacting strongly to everyday occurrences within the gut.
That sounds incredibly uncomfortable, a constant false alarm.
Yeah.
Now, what about the H. pylori connection? Lots of people associate that bacteria with ulcers. Does it play a role here too?
You're right to connect it to ulcers, definitely. But H. pylori can also trigger a sort of low-grade inflammation in the stomach lining, subtly altering its function even without causing a full-blown ulcer.
Okay.
And while it's not the cause for all FD patients, getting rid of H. pylori eradication actually improves symptoms in a meaningful subset of individuals.
So it's worth checking for.
Absolutely. It highlights its potential involvement. And beyond the stomach itself, our sources also point towards duodenal microinflammation and immune activation.
Duodenal. So the first part of the small intestine.
That's right, just past the stomach. We're talking about an increase in specific immune cells, things like eosinophils, mast cells, lymphocytes, found in the duodenum of some FD patients.
And what does that do?
Well, this low-level inflammation can potentially lead to increased intestinal permeability, sometimes called leaky gut, though that term is a bit debated.
Right.
And it can alter nerve signaling in that crucial area where the stomach meets the intestine.
Wow. So it's not just the stomach, but maybe the very beginning of the small intestine is also involved in this complex web.
It seems increasingly likely, yes.
And then we come to that question I mentioned earlier, the one many patients must ask. Is it all in my head? How do psychological factors fit into this physiological puzzle?
That's such a crucial question, and it speaks right to the heart of the gut-brain axis. Psychological factors like anxiety, depression, and chronic stress can undeniably exacerbate symptoms via that intricate two-way communication street between the gut and the brain. There's also evidence pointing to a potential role for altered serotonin signaling, 5-HT, which influences both mood and gut function.
Right. Serotonin isn't just in the brain.
Exactly. Most of it is in the gut.
Yeah.
But it's really important to be clear here. The symptoms are not imagined. They are physically real.
Okay, that's important.
Rather, the brain's processing of gut signals can be significantly influenced, amplified even, by one's emotional and mental state. Your mind isn't just reacting to physical symptoms, it seems to be actively shaping how those signals are perceived through this physiological connection.
So it's not all in your head in that dismissive way, but rather that your head, your brain and nervous system, is a crucial interacting part of your gut's physiology.
Beautifully put, yes.
It truly makes you think differently about how we approach overall well-being, doesn't it?
It really does.
What about the microbiome, the gut bacteria?
Right, good point. Finally, there's the emerging understanding of gut microbiota alterations, or dysbiosis.
Dysbiosis, okay.
An imbalance in the composition or function of gut bacteria might also contribute to generating these symptoms. It could influence everything from inflammation to nerve signaling to motility.
But that's still being figured out.
Exactly. This area is still under active and very exciting research, but it's another potential piece of the puzzle.
That's a remarkable array of potential factors, just highlighting how complex FD really is. So given this intricate picture, what are the common signs someone might experience day to day? And maybe even more importantly, what are those critical red flags that should really prompt immediate medical attention?
Okay, so the common symptoms largely mirror what we've already touched upon. That persistent epigastric pain or burning.
The EPS type symptoms.
Yes, and that bothersome postprandial fullness or early satiety, feeling unable to finish a normal meal.
The PDS type.
Exactly. As well as maybe general bloating, belching, and nausea. Those are the common players.
Right.
However, it is absolutely critical for anyone experiencing these sorts of symptoms to be acutely aware of certain alarm features or red flags.
Okay, this sounds important.
It is. These always warrant immediate medical investigation to definitively rule out more serious underlying conditions, like cancer or significant ulcers.
So what exactly are those alarm features? What should send someone straight to their doctor, no messing around?
Okay, key ones include unintentional weight loss that you really can't explain.
Right.
Progressive dysphagia, and that's difficulty swallowing that gets noticeably worse over time.
Okay.
Persistent vomiting. Also, hematemesis, which is vomiting blood, or Melina-Fel, those dark, tarry stools which indicate bleeding higher up in the GI tract.
Definitely red flags.
Absolutely. Also, a family history of gastric cancer is considered significant. And importantly, the onset of these kinds of dyspeptic symptoms after the age of 50.
Why after 50 specifically?
It's generally because the risk of more serious conditions, including malignancy, increases with age. So new onset symptoms in that age group always need a thorough check.
Got it. So if any of those apply to you listening, it's imperative to consult a medical professional right away.
Without delay, yes.
That's incredibly vital information. So once those concerning red flags have been looked into, hopefully ruled out, how is functional dyspepsia actually confirmed? What's that diagnostic journey typically look like?
Well, the diagnosis of functional dyspepsia largely relies on fulfilling those Rome 4-feet diagnostic criteria we mentioned earlier.
Right, the checklist.
Kind of. It means a patient must experience at least one of these bothersome symptoms: postprandial fullness, early satiation, or epigastric pain or burning. That's step one.
Okay.
Then, crucially, there must be no evidence of structural disease, and that includes looking inside with an endoscopy that adequately explains these symptoms.
So the tests are normal.
Essentially, yes. And finally, these symptoms must have been present for at least 3 months, with their onset occurring at least 6 months before the diagnosis is made. This confirms they're chronic, not just a temporary upset stomach.
Okay, so it's truly a diagnosis of exclusion then. The path involves ruling out a whole range of other possibilities first.
Precisely. You have to be sure nothing else is going on.
So what kind of tests are usually part of that rigorous workup to exclude those other things?
Well, the diagnostic workup typically starts with a very detailed patient history and a physical examination, specifically looking for any of those alarm features we just discussed.
Makes sense.
An upper GI endoscopy is often a crucial step.
Yeah.
It lets the doctor look directly inside the esophagus, stomach, and duodenum to exclude things like peptic ulcers, significant gastritis, GERD complications, or even malignancy.
The camera test.
Exactly. H. pylori testing is also standard. This can be done via a urea breath test, a stool antigen test, or often through biopsies taken during the endoscopy itself.
Okay, what else?
If a specific issue like gastroparesis that severely delayed stomach emptying is suspected based on symptoms, symptoms, then specialized gastric emptying studies might be ordered. These measure how quickly food leaves the stomach.
Right.
Standard blood tests are usually done too, like a complete blood count, CBC, thyroid-stimulating hormone, TSH, to check thyroid function, liver function tests, and maybe amylase lipase to check the pancreas. These help rule out other systemic or metabolic issues.
Okay.
And finally, depending on the symptoms and findings, an abdominal ultrasound or maybe even a CT scan might be used if there's any suspicion of gallbladder or pancreatic problems.
Wow, that's quite a list.
The goal is to be exceptionally thorough in ruling everything else out first before confidently settling on an FD diagnosis.
That's certainly a comprehensive approach, making sure nothing serious is overlooked.
Right.
Okay, so once FD is confirmed, how is it managed? What does a truly multidisciplinary approach to this complex condition actually look like?
Right, so management isn't usually just one thing. It often begins with general measures, focusing first on lifestyle and dietary modifications.
Okay, the basics first.
Exactly. This typically involves practical advice like eating smaller, more frequent meals rather than 3 large ones.
To avoid overwhelming the stomach.
Precisely. And judiciously avoiding specific trigger foods. Common culprits are often fatty or very spicy foods, caffeine, and alcohol, as these can irritate the digestive system or slow emptying.
Makes sense. Any other dietary tips?
Well, if bloating is a particularly prominent symptom for someone, sometimes reducing fermentable carbohydrates, you might have heard of the low FODMA palei.
FODMA-IPS.
That can be quite helpful for some individuals. It's not for everyone with FD, but it's an option to discuss with a doctor or dietitian if bloating is major.
So gentle on the stomach, smaller portions, identify personal triggers.
Yeah.
What about lifestyle changes beyond just diet?
Yeah, beyond diet, lifestyle adjustments are often key. These can include weight loss if a patient is obese, as excess weight can put pressure on the abdomen.
Okay.
Smoking cessation is important too, as smoking can affect motility and acid production. And critically, stress reduction techniques.
Back to the gut-brain axis again.
Absolutely. This is where therapies like cognitive behavioral therapy, CBT, relaxation training, mindfulness, or even hypnotherapy can really come into their own, given that powerful connection we discussed.
That makes perfect sense. You know, the interplay between our minds and guts isn't just theoretical. It clearly has tangible physiological impacts, which feels like a powerful insight for managing this.
It really is. Empowering patients to manage stress can have a direct benefit on their gut symptoms.
So what about medications then, when lifestyle and diet aren't quite enough?
Right. Pharmacological therapy can be quite varied and needs to be targeted to the patient's main symptoms. For epigastric pain syndrome, EPS, where pain or burning is dominant,
Yeah.
acid suppressive therapy is often a first line, usually using proton pump inhibitors or PPIs. You'll know names like omeprazole, pantoprazole,
Oh yeah, very common.
very common. Or sometimes H2 receptor antagonists like famotidine might be used as an alternative or addition.
And what about for the PDS symptoms, the fullness and early satiety?
For those, or if delayed emptying is suspected, prokinetic agents might be used.
Prokinetic, meaning they promote movement?
Exactly. They aim to improve gastric motility, helping the stomach empty more efficiently. Examples include drugs like metoclopramide or domperidone, though their use can be limited by side effects or regulations in some places.
Okay.
Sometimes, even the antibiotic erythromycin is used in low doses, not for infection, but specifically for its prokinetic effect in more severe, stubborn cases.
Interesting. And if that specific bacterial culprit, H. pylori, is found during the workup?
Ah, yes. If H. pylori testing comes back positive, then eradication therapy is definitely recommended.
What does that involve?
It typically involves what's called a triple therapy. Usually a PPI combined with 2 different antibiotics, often clarithromycin and amoxicillin or metronidazole, taken for about 10 to 14 days to clear the infection completely.
Right, clear the decks.
Precisely. Then for patients where that visceral hypersensitivity seems to be a major factor, or where anxiety and depression are significant components, neuromodulators can be very effective. These aren't primarily for the mood issue itself in this context, but more for their effect on gut sensation and motility.
Okay, so what kind of drugs are we talking about?
Often low-dose tricyclic antidepressants, or TCAs like amitriptyline, or sometimes selective serotonin reuptake inhibitors, the SSRIs like sertraline or citalopram.
Wow, so antidepressants used for gut symptoms.
Yes, in lower doses than typically used for depression, they can modulate those pain signals traveling along the gut-brain axis and improve overall gut comfort and well-being.
It's truly fascinating how medications we usually associate with mood can have such a profound impact on gut symptoms. Really underscores that gut-brain link.
It absolutely does. It's a prime example.
Are there any other specific agents sometimes used for FD?
Yes, a couple others mentioned in the sources include buspirone. It's usually known as an anti-anxiety med, but it can also help improve gastric accommodation, that stomach relaxation we talked about. And mirtazapine, which is another type of antidepressant, might be considered. It can be particularly helpful if nausea or weight loss are significant concerns, as it can help stimulate appetite and reduce nausea.
Right. And beyond medications, you mentioned psychological therapies earlier.
Yes, and they are really vital, reinforcing the importance of that gut-brain connection. Things like cognitive behavioral therapy, CBT, gut-directed hypnotherapy, and biofeedback can empower patients.
Oh.
They teach coping strategies and can help patients directly influence and better manage their symptoms by working on that gut-brain interaction, changing how the brain processes those gut signals.
That sounds really empowering. And what about therapies that are maybe still on the horizon or perhaps have less robust evidence but still show some promise?
Yeah, our sources do touch on some emerging therapies that are being explored, although the evidence for them might still be considered limited or preliminary for widespread use.
Like what?
These include certain herbal preparations. One often studied is known as STW5, or iberogast, which is a combination of several plant extracts.
Okay, herbal options.
Also, specific probiotics aimed at trying to rebalance the gut microbiota are being investigated, though finding the right strains for FD is still a work in progress. And even acupuncture has shown some promise in small studies for symptom relief.
Interesting. So lots of research still happening.
Absolutely. While more rigorous research is always needed for these, they represent how researchers are casting a wider net, looking beyond conventional drugs and exploring other potential pathways to relief.
So it really sounds like FD is a condition that truly benefits from a multifaceted approach. Managing it from multiple angles, highlighting that need for multidisciplinary teamwork, doctors, dietitians, maybe therapists.
Exactly. It often requires that kind of coordinated care.
So thinking long-term then, what's the typical outlook for someone living with FD? Is it something you cure or manage? And because it is a diagnosis of exclusion, what other conditions might mimic it so closely that doctors absolutely need to rule them out first?
Right. Well, functional dyspepsia is often a chronic relapsing condition. That means it can stick around for a long time, and symptoms might flare up and then settle down again. It has a variable course.
So not always straightforward.
Not always. While studies suggest about 50% of patients do experience significant improvement with treatment, symptoms can certainly recur over time. It often requires ongoing management rather than a one-time cure.
And what leads to the best outcomes?
The best, most enduring outcomes are typically seen with that comprehensive multidisciplinary approach we've been discussing, combining tailored dietary adjustments, appropriate medications when needed, and robust psychological support or stress management.
Right, hitting it from all sides.
Pretty much. And regarding what needs to be ruled out the differential diagnosis, it's absolutely vital for clinicians to exclude conditions that can present with very similar symptoms.
Like what, for example?
We've touched on some, but key ones include GARD, gastroesophageal reflux disease, peptic ulcer disease, gastroparesis, that delayed emptying, chronic pancreatitis, and various gallbladder diseases like gallstones.
Okay, quite a few overlaps.
Definitely. And of course, although much rarer, gastric cancer also needs to be definitively excluded, especially if those alarm features are present or symptoms start later in life. This really underscores why that thorough diagnostic process is so crucial before landing on an FD diagnosis. You have to be sure you're not missing something else.
Absolutely. Okay, so wrapping this up, what does this all mean for you, the listener? Functional dyspepsia is clearly a legitimate, impactful condition. It can significantly affect quality of life, even though it doesn't show up on a traditional scan or test. It really stands as a prime example of the incredible complexity and interconnectedness of our bodies, particularly highlighting that fascinating gut-brain axis.
It really does.
We've seen how factors ranging from subtle shifts in stomach motility, how the stomach moves and accommodates food, all the way to the very balance of our gut bacteria and even our emotional state, can all play a significant role in how we experience our digestive health.
Yeah, and this deep dive truly reveals that sometimes the absence of a clear organic cause, something you can see on a test, doesn't mean the problem isn't profoundly real or that it isn't effectively treatable.
Right.
It really invites us, I think, to consider how much more there is to learn about the subtle yet incredibly powerful interactions happening within our own systems. It challenges us to look beyond just the obvious structural issues.
A really important point.
So, thinking about everything we've discussed, what stands out to you about this condition? And how might this understanding of something like functional dyspepsia potentially shift your perspective on how we approach health and illness more broadly? Something to think about.